So the theme of this panel is serving individuals with disabilities. And I have Dr. Scott Howell here with me, and I have Mr. Dennis Borel. And so first, I'm just going to ask the both of you to introduce yourselves and give a little bit of background about specialty care dentistry and about serving individuals with disabilities and advocacy. And so, Scott, we'll start with you, if that's all right.
Sure. So good afternoon. I know you've already heard my voice a couple times, but this is what I look like. I got started pretty early as a dental assistant, going into unique locations like inner city schools, nursing homes, and detention centers. And it was in the nursing homes where I started getting exposed to people that we bundle in the special care dentistry community. People with complex medical conditions, geriatric communities, Alzheimer's, dementia, things like that. After graduating from dental school, I had this grand plan to open up a hospital residency, and so I needed additional training. The Arizona School of Dentistry and Oral Health, where I went, has a phenomenal special needs clinic, but I wanted more training in hospital dentistry and more advanced special needs. And so I did a one-year residency in Seattle at Swedish Medical Center and had an interesting year. But it was sort of in that realm that I realized that the public health, the advocacy, the policy, the education, those are the areas where I really wanted to focus my efforts. So now I'm working back at the Arizona School of Dentistry and Oral Health, working on a teledentistry project. We have a small project with people with special needs, but also continuing to work with unique populations that, to me, it comes down to the education of the providers. The populations that we try to focus on don't have. One of the biggest access issues is that the providers aren't comfortable, aren't ready to treat the population. And then I also serve as the treasurer for the Special Care Dentistry Association, which represents about 550 to 600 dentists, hygienists, assistants, and other healthcare professionals. We have an annual meeting. We provide educational information for providers, and we make up. We're a tripartite of sorts. We have people interested in dentistry for people with disabilities, hospital dentistry, and geriatrics. And I do just want to point out our immediate past president, Dr. Sam Swetchkenbaum, is sitting in the back. But although here you're representing Rhode Island, but I just couldn't not say hello. So
Thank you, Scott. We appreciate you joining us today. Dennis, do you mind sharing a little bit about yourself and your background?
Sure. My name is Dennis Borel. I'm with the Coalition of Texans with Disabilities, which is a nonprofit, statewide cross-disability advocacy organization. That means we focus on changing policy. And I always like to tell people, if you know what you're doing and you can't take care of your business because of some rule or regulation, you can do one or two things. You can change doing what you know how to do, or you can change those rules and regulation to fit, because you know more than the people who are making those rules and regulations. So we've been around since 1978, which is a pretty long time for a disability rights organization. You know, I really enjoyed the race discussion earlier today, and I always say that people with disabilities are a minority themselves. And as a demographic group, people with disabilities have the lowest income in our society. They have the highest unemployment rate. They're least likely to own a car or their own home. They're more likely to die prematurely, but not due to their disability, due to substandard health care. And the simple right to be free of discrimination based on your disability is only 30 years old this year with the Americans with Disabilities Act. Can you believe that? 31 years ago, it was perfectly legal to discriminate against someone on their disability. And of course, discrimination remains with us today. We work primarily with the state legislature here in Texas and the agencies. But we also do some federal stuff, and we work with a lot of provider communities. Dental is like become a personal issue for me now, and the reason why is I'm around a lot of adults with disabilities. They're my members, my coworkers, and they're my friends. And you can't be around a group like that for any length of time without noticing the condition.
We'll edit that out of the podcast.
So that's quite the swear word.
Dennis was getting very heated.
With that, I'll go back to Annalise.
Thank you. Thank you for introducing yourself and sharing with us about your work. I thought we would start off today, as Dr. Tyler Sanslow was mentioning earlier today with LGBTQIA populations, how terminology is really important, and it's really evolving. So how we talk about that community, how they identify, all of that's really important for us to understand as we interact with them. And so Dennis, I'll start with you if that's all right. How should we consider speaking about this population? How do they consider in terms of how they want to identify and relate? How should we be utilizing appropriate terminology?
Let me see if this is going to work. Okay, that's
There we
good.
go.
I'm back. Okay, the key to be politically correct these days and socially correct is people first language. So you don't identify people by their disability. Therefore, a person is not a paraplegic, he is a person with paraplegia. If you can use just the person's name, that's a whole lot better. And think about it, if I'm with my colleague Chase, I don't really have to say, yeah, this is Chase who uses a wheelchair. You can see he's sitting in a wheelchair. You can see he has an injury that necessitates that. So get away from referring to people with disabilities by any type of diagnosis or characteristic of the disability. Just refer to them as the human beings they are. And I'll tell you, that's all they really want. They don't want special treatment. They just want equal rights.
Yeah, thank you. Scott, Dr. Howell, you are a dentist. How does this reflect in the patients and when you're treating this population? What sort of terminology, that person-centered terminology, should we be incorporating and using?
It's exactly the same. We teach our students at ASDO, Arizona School of Dentistry and Oral Health, and that's what I was taught. The interesting thing is, very often, your patients are going to come with a guardian of some kind. And there's multiple guardians they may come with. They may, and I'm using the word guardian a little bit loosely here, but they could come up with someone who's just a transportation person, someone that brings them from the group home or from their home to you, and that person can't make decisions for them, so you really can't ask them. But that guardian, like a parent or a power of attorney, that's an important person that may be part of the conversation, and they may have preferences, because you might be working with someone who's nonverbal, and you might not be able to have an oral conversation with them, but body language is still huge, and how you approach them with your demeanor will also impact them. So I think language, in a way, comes as nonverbal language. But I think back to one of my good friends and colleagues at the dental school, she has 2 sons with autism, and an older son who, when he was diagnosed, it was mentally retarded. Now, the Special Olympics has a campaign to end the R word. This isn't considered an appropriate term to use anymore, but my colleague says that's what his diagnosis was when he was born. And so she has a really hard time when people want to say that he's something else. And she's like, no, that's what he was, and now you want to change it on me. So I think it's important when we're using language to also respect what the person calls themselves, which, again, may or may not be possible based on the person's ability to communicate in a traditional way to communicate.
Yeah.
May I add one little thing to that?
Absolutely.
I had one thing, that retardation. So what changed? What changed is that is a word that moved over from the medical lexicon into the common usage as an insult. That's the same thing that happened to the word idiot, imbecile, and cretin. Those were all words that started in the medical vocabulary that crosswalked over into everyday speech as insults. And that's why that isn't appropriate. I understand that. And the R word, never to be used.
Right. Thank you. I actually didn't know that had started, the terms you mentioned had started in medicine and crosswalked into sort of our everyday usage of those terms. We do have a question coming in, and it relates to the terminology. Can you discuss the different categories of the, quote, disabled population that you're referring to, both broadly and as they relate to dental care?
You know, I think disabled is an interesting word. You'll hear a lot of times differently abled. And I think that's the way to really approach this. To discuss the different categories, in my world, like I said, in the world of special care dentistry, I lump it into 3. Geriatrics, which you're dealing with more metabolism issues, the issue of medication changes. You have issues of end of life that you're going to work around, palliative care, things like that. You have disabilities or people with disabilities, which are what we tend to generally think, neuro and intellectual disabilities. And then we have hospital dentistry in my world, which is the medically complex patients, the patients with liver disease, the patients with advanced stage cancer, and how do we treat them dentally. In terms of dental care, I try to work with the students with this. We're not doing a substandard of care. We're providing care in a way that meets the patient where they're at. If the patient can't brush every single day, then what can we do to modify the care regimen that will make it easier for them? Maybe it's just because they have cerebral palsy and they don't have as much control over their hand. Well, what other tools are out there? Maybe they have rheumatoid arthritis and they can't squeeze the toothbrush. There are some great big handled toothbrushes, or you take a tennis ball, or you take a bicycle handlebar grip and put it at the end of a toothbrush. So as it relates to dentistry, it's all about what are we doing to modify the dental care to meet the needs of the patient. And it's changing our mindset that we have to be perfect, because working with patients with disabilities, you can still do an amazing job, but you have to recognize the limitations of the patient and the limitations of the situation, which is difficult to do when you're surrounded by a bunch of type A personalities.
Yeah, and I'm hearing you talk about just the level of innovation that individuals in this community really have to incorporate in their daily lives to make up for the deficits that the system imparts on them. Dennis, did you have a response or a reflection to that?
Scott's got it exactly right. I don't believe in categorizing by disability. If you're going to look at different types of people, you should categorize by functional need. You know, do they need help with manual toothbrushing or other ways to do it? That's the way to look at it, not by disability, but by functional need. That was a spot-on answer, Scott.
Before I forget, and I have to make sure everyone's aware of Special Books by Special Kids. This is a YouTube channel that if you're interested in teaching people what someone with a certain disability looks like, talks like, how they communicate, this gentleman goes around the world to interview people with special needs and disabilities, from invisible disabilities like PTSD or schizophrenia to very visible ones, that syndromes you may have never heard about. It's an awesome resource to learn about the unique variety that exists within this community.
Yeah.
Special Books by Special Kids. It's a YouTube channel, SBSK, if you type in SBSK YouTube or Special Books by Special Kids.
And now I've heard both of you touch on this subject, and I think this is probably one of the first things that we think about here when we're talking about health equity, and that's barriers to accessing care. And then barriers while you're accessing care in terms of clinical maneuvers and special innovative techniques that you have to learn and be educated on. And so as an abled individual, I often don't have to consider what I need to do to go, to the dentist. I just go to the dentist and I show up, and I have access to care, and that's sort of my privilege as an able-bodied individual. So can you help us understand some of the barriers that they experience, and then also share some of the successes, the solutions that we sort of come across throughout the years? Scott, is it okay if I start with you?
Sure. Being in academia, I think the biggest barrier I'm always going to maybe come back to is the education of our future providers. And with that being said, the education of our current providers. Dentistry for a long time has not made this a priority. Dental education has not made it a priority to help our patients with atypical presentations. And past few years, the CODA accreditation standards changed. We got a little win, where CODA required dental schools to assess a patient with disabilities, a special care patient. And assess just means, you have disease, good luck finding a doctor. The change recently, and I think it's being implemented this year, I don't mean to get these dates wrong, but it's slipping my mind, is to manage a patient with special needs. And so that's going to be more hands-on. Mm-hmm. But the challenge I see is that now schools have to do something about that. Now schools have to be ready to manage people with disabilities, from having doors wide enough that it can accommodate gurneys and wheelchairs, to having dental chairs that can hold a patient with a movement disorder, to having an operatory big enough that the wheelchair can fit a wheelchair and a provider and maybe a caregiver. I think education is going to be crucial, and I think we've been making great strides in education. Our general practice residencies that are based in hospital settings that offer training in special needs and medically complex, we really have come a long way. I think there are some resources out there for the practicing provider, someone who's been in the practice for a while. I've shared it with Annalise, and I think it'll be available on the website for a few different courses that are available, some free, some paid. SCDA offers a course. There's a course through A.T. Still University, where I teach, and UCSD, University of California, San Diego. They have a joint course for free. And so that's part of the process to overcome some of these barriers. But they are physical, they are mental barriers from, I can't do this, I've never seen this patient before. The moment you expose yourself to one person who falls into this category, you realize, oh, I can start doing this. I think that's crucial.
Dennis.
Well, I'd say that you covered the clinical side beautifully. To me, the forgotten section of the community of people with disabilities when it comes to dental care is the adult with disabilities. Children with disability, and I have to say I'm speaking on the Texas Medicaid system. If you're from other states, you may have a better plan, or you may have a similar plan. But in Texas, once you hit adulthood, you lose essentially your dental services, except for what they euphemistically call emergency. I give those air quotes there, emergency dental. Emergency dental in adult Medicaid, and if you recall, my first statement is that people with disabilities are the lowest income demographic group in our society, so where are they overrepresented? In the Medicaid population, which in Texas is only for very, very poor people. So we have this mass of adults that aren't getting any dental care except this emergency care, which means if you're in agonizing dental pain, you go to the emergency room where you get antibiotics and opioids likely. In fact, 50% of adults in Medicaid that present at emergency rooms with dental pain leave with an opioid prescription. Now that's one of the hidden parts about the opioid epidemic that we are creating that is not being talked about. None of these would happen if there were a simple preventative dental service in Texas Medicaid. Right now, and there's some stuff you'll see that I uploaded, but it's the same for every payer. An ER visit costs 9 times what it costs a visit to a dentist office. If it's admission to the hospital, it's 230 times as expensive as a dental visit in the office. And almost every one of those ER visits or inpatient admissions could have been avoided with just regular preventive dental treatment. Now, so apart from the tremendous humanitarian benefits of having good oral health, right there is a money issue that to me, the legislators ought to recognize and make this an available benefit.
Yeah, and you kind of walked into my next question. I know we have some questions here from the audience, but I think I want to sort of elaborate on that.
Yeah.
Because the theme of the colloquium is talking about the intersection of health equity and policy. And so you've touched on some of those policy solutions that can really eliminate and reduce barriers to care. So is there anything else that we can consider policy-wise, federal, state, or local, to help increase access to care for this population?
Well, the other one on the federal level is there's still an ongoing effort to include dental in Medicare, which actually did pass the House. It's unlikely to pass the Senate because it was embedded in other legislation related to pharmaceuticals, which is another hot issue. But it is mostly on the state level is where a lot of these decisions are being made more so than the federal level. And the locals, well, that's up to them. Yeah.
Scott?
Federally, there's the, I forget where they were trying to do this, but the American Academy of Developmental Medicine and Dentistry, which is a joint medical and dental group for people who treat patients with special needs. They're aligned really closely with Special Olympics. They were working on, and maybe Sam, you can help remind me here, they were working on some policy to get people with disabilities recognized as a medically underserved group. And by changing that policy at the federal level, it was going to lead to more opportunities, maybe at the state level. And I don't know all the specifics here, but I know that was a federal push. In Arizona, we reinstated a $1,000 comprehensive dental benefit for people with disabilities through one of our Medicaid plans. But here is the kicker. That $1,000 also covered the sedation and anesthesia, general anesthesia. Right. So if you've worked with people with disabilities, you know that you might need to use sedation or general anesthesia to accomplish the procedure. Well, $1,000 gets eaten up within the first half hour to hour, and so now you have nothing left for the dentistry. Now that has to do with policy before, because it used to be there was no cap to it before. So when they got rid of it, then brought it back, they put the cap on it, not thinking about the impact. And that's been 2 or 3 years, and they still have yet to remove that cap. So that's a policy issue, a legislative issue that is severely impacting access.
And I want to hit on a follow-up question from an audience member, because we're talking about policy, and we've talked throughout this conference a lot about research. And so it's really hard for us to come up with policies when we don't really have all the information we need about the population we're trying to serve. And so there was a question about what type of research is needed to advance the needs of those populations. Scott, I'll let you address this first.
Has anyone heard Marko Vujicic talk from the ADA? That man can make statistics just sexy. And he came and spoke to SCDA a few years ago. Do you remember, Sam? And sorry, I keep pointing you out, but my favorite guy over here. He came and talked to us about just the stat, just the numbers, the basic raw numbers of people with disabilities and the lack of care they were getting. And the group, and Marko, what he said is, we don't know why these numbers are so bad, though. All his data showed was, here's how little access they have, and here's the levels of disease that they have. And so I would say, if as an organization as powerful as the ADA can't really answer some of the details, we need to get to those details why. I think we know generally, people anecdotally know what the problems are, but we need to start answering why so we can start working on those policy, those education things. I mean, like in academia, we say, well, students aren't being trained. In the communities, they're saying, well, there's no dental coverage, there's no providers who will take them. But I'm not aware of really good epidemiological studies answering the why.
Yeah. Dennis, what do you think?
Well, certainly, I would say collecting some of the available research out there is what's needed. And so, as I mentioned, the one about 50% of adults on Medicaid who present in the emergency room leave with an opioid prescription, that is a powerful statistic that was not publicized until within the last year. This is a study on the cost of treating various chronic illnesses if the patient has had preventive dental versus those that have had none. In other words, people with bad oral health versus good oral health. Coronary heart disease, it costs 67% less to treat somebody with coronary heart disease if they don't have bad oral health. Diabetes, it's 36% lower. High blood pressure, 31%, stroke 52%, cancer 67%, asthma 37%. So what is undoubtedly true, and no one disputes this, is that poor oral health leads to complications in the rest of the body, including chronic illnesses. And so those statistics I mentioned all actually, they're actually much more impressive when you think that a lot of people with good oral health never develop diabetes because of their good oral health. So this is only the ones that develop diabetes. So the actual amount of human cost and financial cost that can be saved when you look at the full healthcare cost, because people are made up of all their different healthcare costs. As somebody who works in public policy, I get told, well, you got to focus on drug cost, you got to focus on physician cost, hospital cost, and break those down. I said, you don't do that, because people aren't made up of different pieces. And if I want to say, well, I'm going to save money on physicians by not having go to my friend Scott, who's a dentist, well, you know what? I'm actually paying more money in another part of the silo. That's bad public policy. So we have those. It's like we need to change the way people think.
Yeah.
It's doable. This is not rocket science. I guarantee you, if I could have every one of you send me your emails, it's on the form, I'll keep you apprised. and we can help change this in 2021.
Yeah, so I'm hearing both of you say that there is available research, but maybe we're not using it in the best way and we're not understanding sort of the underlying context of how to get to it. And it kind of brings me to my next question, which is from an audience member saying, why do you think oral health community has so much trouble communicating with policymakers about the cost effectiveness of the changes that we're talking about? So we have the data, but it seems like we're struggling to communicate the why or sort of the storytelling aspects. In your opinion, how are we struggling to sort of bridge this gap? Scott, is it okay if I start with you?
Talking to one of my students recently, they said, I really want to help make change, but I don't like politics. Fair. I don't even think politicians like politics. What I said to them, though, is not about the politics. It's that you know the stories. You're the advocate. You have the boots on the ground, hands in the mouth experience that if you don't share that story with your legislators and your congresspeople, they aren't going to care. And so I think it's reframing what advocacy is. I think it's let the lobbyist, and I was just talking to Joshua from Interfaith talking about lobbying. There are people whose jobs are to lobby. I'm making a bit of an assumption. I think that's your job is to lobby. Let them deal with the politics, but you be the voice, especially given that this population, as I mentioned, is often nonverbal or communicates in a way that makes people uncomfortable. We got to get over the discomfort, but beyond that, sometimes we need to advocate for our patients, and that's an easy thing to do. But I think we need to reframe what advocacy looks like and encourage people to just tell a story, because that's really all it is.
Yeah. And Dennis, this is really your area of expertise. This is what the Coalition of Texans with Disabilities, this is what you guys do.
That's right.
So where are we missing the mark as advocates, and how can we support that work better in terms of communication?
Well, actually, I don't think we're missing the mark. We've actually shown steady progress when we first started doing this. In the 2 sessions that have passed, we went from getting the legislature to agree to even study this as a real issue to pass the legislation in 2019 to create a pilot, which is the first time an adult dental benefit has ever existed in language in Texas statute, and we're going to build on that. So we're getting there. It's a slow process. So I will give a shout out to Josh Houston. Many a time we were shoulder to shoulder running through the Capitol doing the political side of what you're talking about. And a shout out to Michelle Landrum. Michelle, are you still? Oh, okay. So Michelle, who's part of the Texas Oral Health Coalition, as I am, invited me to come over to her class, dental hygiene class at Austin Community College. Went over there. Then her group came over and spent half a day in the Capitol. We broke them up into groups. And they went around as dental hygiene students talking to staffers and legislators about this issue. And the next day I got a call from one of the state reps that they spoke with and said, we're filing the bill for you. So it does work. I've also worked with the Texas Advocates, which is a group of adults with intellectual and developmental disabilities, got them into the Capitol. And they were the face of the issue, including their, sad to say, their oral health was the face of the issue. Mm-hmm. So it can be done. We're making progress. We got to close the deal.
Yeah, and I'm hearing both of you echo really that undertone of needing strong storytelling.
Yes.
Of needing people showing up to tell their stories.
Yes.
And that seems to be the most powerful way to communicate.
Especially if they're constituents of the person they're talking to.
I'd like to shift the conversation a little bit to take another audience member question, because I'm really interested in hearing your take on this too. How do we prevent predatory practices of those providing care to people with disabilities, which often max out benefits regardless of health needs and outcomes? Dennis, I'll start with you. Predatory practices and predatory individuals in terms of individuals with disabilities in that community.
Yeah, it was a big issue a few years ago regarding the kids program that, supposedly a lot of kids were getting unneeded orthodontia work because it was essentially easy money. It turned out that supposedly the contractor that the state paid tons of money to was simply rubber stamping things. That has been fixed. I understand that they've gotten that under control. But, as usual, it was they had the fox guarding the hen house. And so while a bunch of money was spent, it went to kids who didn't need it. Some of them did need it, of course, and those that need it should still get it. but those that didn't need it got it and may have had other complications. That's plain old predatory stuff and not acceptable, you know?
Yeah, I'm not aware of this happening. I'm obviously predatory practices, yes, but with this particular population, I'd say would be news to me. Maybe I'm just naive and young. I think
Are you saying I'm old?
well, you've done this longer than I have. I think it would take, you know, like there are people who are trained in this area, and that if there's going to be policies put in place, if there's going to be systems put in place, like a Medicaid system, you know, if you're going to have someone check off that the procedure, you know, if you have pre-auths, things like that, then it should be someone that's had a GPR training or done a fellowship in geriatrics or a fellowship. Because there are fellowship programs, there aren't a whole lot, but there are fellowships for people with disabilities. The Rose F. Kennedy Center is a phenomenal program out in the Bronx, I think. So having people who have been trained in these particular areas that they could spot unusual practices and making sure they're part of your team. I'm looking at the insurance folks in the office. I'm assuming, you know, you want them on your teams to keep an eye out for odd billing and charges and things like that.
Mm-hmm. So we have a few questions from the audience that revolve around education of patients and providers. And Dennis, I remember speaking with a member of your staff, and we tend to put a lot of emphasis on educating patients, and we don't realize that, particularly with this community, that educating caregivers is often just as important, and policies that relate and support caregivers is often just important. And so one of the questions from the audience member is, are there any policy or practice recommendations for patients who present with transporters or who are not familiar with the patient medical dental history and are unable to encourage home care, which sort of falls into some of the other questions that we got about how do you impress the importance of oral health to patients and their caregivers. Scott, I'll start with you.
Sure. I can't remember. I have this really good habit of someone telling me a great story, and then like a week later, me telling that person the great story they just told me, because I forgot they were the ones who told me that story. So if someone in this audience told me this story, I apologize. But there was a situation where, you know, some states want to expand opportunities for hygienists to work under general supervision. I don't know what state it was. Maybe it's better that I don't remember what state it was. But the challenge was the hygienists were going to go out and train caregivers, like certified nursing assistants, people like that, on how to brush teeth and how to take care of oral health at home. When someone can't do it on their own, someone with Alzheimer's, dementia, someone who is paraplegic.
Sure. Good.
Right? First language. But the challenge, someone was fighting that. Someone didn't want the certified nursing assistants. I think it was a hygiene association was actually fighting it. Didn't want the certified nurses to have these skills. And I'm kind of thinking, why we can't. We've got to get rid of this protectionist behavior. We've got to open up the opportunity for others. When we can't be everywhere, we need to expand other people's opportunities. I mean, you're brushing teeth. There's not, I mean, I guess you could, I mean, if you shove the toothbrush down their throat, yeah, that's harmful, but like, that's just not possible, you know? We talk about, you know, a big issue with some of these populations is swallowing, you know, making sure you don't use a lot of water because a patient with Alzheimer's might aspirate on that, or a patient with cerebral palsy maybe can't swallow. So we talk about these things, you know, we train people to be aware, and if they aren't comfortable doing it, they give us a call and we talk through it. Maybe the hygienist talks through it with them. So there is an absolute need, because as dentists and hygienists and community dental health coordinators, we can't be everywhere. So we need more people that can help us. That's a big thing for me that I'd like to see more of happening for caregivers in particular.
Mm-hmm. Dennis, any thoughts or reflections?
It's real. And I would say when I think of caregivers, I think of the two groups of caregivers. There's what we call the informal ones, typically family members. Those folks usually do an exceptional job, and they understand how to brush teeth, and they understand the individual they're working with. The question comes on what we call the paid caregivers, primarily Medicaid. Now the issue there is that is the lowest paid healthcare job in this state, and probably in most states in this state, it's slightly, the base wage is $8.11 an hour, so you have a lot of turnover and a lot of low-skilled people. So in a way, we're making our own bed there by selecting for people with very low skills, even though with some training, which again we don't make available, they would be able to do an improved job. Because as we all know, if you can keep people healthy, that's actually the greatest key to cost containment in public health programs. And so it can be done. We should be doing more about it, and that's actually a really good question.
Mm-hmm. I think it also reflects some of the structural issues. So when we talk about the different layers and levels that we're assessing here, and an audience member asked this early on, we're not just talking about an individual, we're talking about their caregivers, their family, and it really does extend just beyond that. Then we're talking about the systems in which those people also interact. And so one question we got early on were, dentists are often the most comfortable in their own office and not everyone can access your office, so how can we bridge this gap? So I think that's a specific question, but I also think it speaks more to the structural and systemic issues faced by this population. So I'm wondering if we can sort of broaden that out. And maybe, Scott, you can talk specifically about access within a dental office, and you sort of touched on that earlier. And then maybe we can talk more broadly about systems change needs that we see in this population. What do you think, Scott?
I think it's really interesting. This is, I really like this question because dentistry historically has been so single provider, small offices. It's really going to be interesting to see where we go with corporate dentistry, to see how the corporations, when they come in, the DSOs and the DPOs, how they may impact what the dental office looks like, how teledentistry, that's what I do at IT Still, how that might impact what the office actually looks like. I don't understand all the ins and outs of the ADA, but I believe you can't go to someone and say you have to overhaul your office to make it accessible. That might be cost prohibitive. But I think going forward, because there are always new dental offices opening, this needs to be in place. Your doors need to be accessible, maybe not to the most unique situation like a gurney. I mean, I've worked with patients who come in that come in through the ambulance, but at least wheelchair accessible, that operatories be a little bit more functional for what's available, that the dental manufacturers are creating equipment that is more, not portable, but stationary in the office, but can somehow be moved around the office to make it more accessible. I hate to make things government regulated though, because I don't think it's necessary to strong arm people into doing it, but if we can demonstrate the benefit, that if you treat that person with special needs, you treat the person with Down syndrome, with autism, with whatever, and they're going to bring their whole family to you. They're going to tell their friends and their family to come see this person who sees my child, who takes the time for my child. So I think where we're at now, I don't know what kind of change we may see there. That might be really difficult, but I think moving forward we have opportunities for sure.
Yeah, absolutely. So Dennis, what do you think about moving away from this traditional model of how we're thinking about patient care and accessibility and moving into systems change thinking?
Well, I'm not so sure that there needs to be a lot of systems change in this area. There is some regulations surrounding the Texas accessibility standards and the ADA that open up things. To me, there's two things. Number one is ask your patient, okay? Ask them. And they might say, and she might say, you know what, I'll just stay in my wheelchair. You don't have to try to get a bunch of people to lift me and transfer me out. But what if I just stay in my wheelchair? So ask the patient. They know very well what they need, okay? And then the other thing is, what you also touched on, Scott, I've heard more complaints about like attitudinal things, that they didn't feel welcome in a certain dentist's office and they were looking for someone else. So it really is a matter of feeling welcome and feeling like they're being treated well. And if you just say, yeah, this is going to be really hard to do this, almost every individual I know with a disability understands what accommodations they have, what they can't have, and how they can get around them. Right. So asking them, they're the experts.
Right.
And I will say, be afraid to be wrong. No, don't be afraid to be wrong. Don't be afraid, edit that. Don't be afraid to be wrong. I think your patients will 99% of the time forgive you. I had a patient with a movement disorder in the nursing home when I was a dental assistant, so not even a baby dentist. And I was taking x-rays, and she had a movement disorder, and I said, okay, on the count of 3, stand still, 1, 2, 3. And she kind of looked up at me out of the corner of her eyes, and I looked down at her, and I was just like, I am such a jerk. And she smiled, and she knew that I didn't mean, it's just what I always said. So I think that's allowing ourselves to forgive ourselves, because our patients almost always will, because they know just the fact that we're there, that we care, and we're trying.
Thank you. That's really helpful. I'd like to hear a little bit more about success stories. I want to hear, what are we doing really well? I think we tend to focus, particularly in health equity, on all of the problems that we need to fix. And sometimes that feels overwhelming. And when we're constantly focused on the gaps and the flaws, we forget to celebrate our successes. So I thought maybe we could spend a little bit of time celebrating some of the successes. Dennis, is it okay if I start with you? And maybe you can share, I know you've shared already some of the policy successes that we've seen here recently, but where are other successes?
Yeah, there's one that I see that reflects incredibly well on the community of dentists and themselves, and there's quite a number that'll take on a pro bono patient or two, a person with a disability, an adult who, that means that dentist is not going to get paid, and yet they do that, and I know several dentists in Austin that do that. And the impact they have on those patients is fantastic. There's no question about it. There are also some groups, like some of the faith-based groups will have dental days. The St. David's Foundation, has a program, and we can hear from NC about that too, where they go out and do a lot of dental services. Those are all really great things. The need is much bigger than all of these pieces, but there's some really kind-hearted, excellent pieces out there. We just need more money so we can expand that to the larger population that needs it.
And I'm hearing from both of you, there's a lot of passion from the people in this work, the providers, who really want to see good outcomes for their patients.
They tell me, my personal dentist tells me his most rewarding experiences is when I've introduced him to his pro bono patients. So I think that is true.
Yeah. Scott, what do you think? Where are our successes? What are we doing well? Where are the bright spots?
I felt like there was a time just recently where, I don't know if it was the ADA, like the daily news that they come out with, whoever it was, but talking about new special needs clinics that were opening up in dental schools. I want to say Penn has opened one, NYU, and it was in such a short amount of time. And that's what kind of surprised me. I was just like, wow, there's a lot of traction coming here. And maybe because it's CODA, maybe the Dental Commission on Dental Accreditation, maybe that's what's driving this. I'm not entirely sure, but there is a recognition here. I think we've really started to change dental residencies from being a 5th year of dental school to awesome learning opportunities. I'm referring to AEGDs and GPRs. GPRs in particular, because that's where this population tend to be seen in the hospital settings. GPRs focus more on special needs, but some really amazing learning opportunities for our graduates. And then I go back to the corporates, and I don't work with the corporates at all, but Pacific Dental Service, I was telling you a few minutes ago, Sugarland Modern Dentistry, Jacob Dent, Dr. Jacob Dent, if anyone knows him. I believe it's his office, that particular office where he, supported by Pacific Dental Services, if I have all my names correct here, has a whole suite for people with sensory disorders and kids with autism and things like that. PDS, Pacific Dental Services, also opened up a clinic in Phoenix to focus on people with special needs. So I think there's a lot of driving forces behind people wanting to do better.
And I think you're also touching on some of the, again, sort of bringing it back to policy, because I think we have had policy successes, and we've gotten several questions here about why some of them haven't worked or why some of them have. So I know we've talked a little bit specifically to Texas, that we have we didn't accept Medicaid expansion, and we haven't expanded Medicaid to cover individuals with disabilities or to any adult dental benefit. So in terms of maybe why those policy solutions are working or not working, do you think we can maybe shift into there? Because there was another question too on metrics. And I always think about as a researcher that data and policy are so inextricably linked because we base a lot of policy on what we can quantify. So maybe shifting back to sort of close out this discussion today on policy and what we're doing well and how we can shift policy too. Dennis, I'll let you take this one to begin with.
Well, it's going to have to be a Texas-specific answer, and our Texas legislature, our Texas state elected officials are dominated by people who believe in limited government, unless they want to interfere with certain women's rights. But this is true, and which is why they have steadfastly denied expanding Medicaid, which is why they have denied an expansion of things like medical marijuana, both of which are hugely favored by the people. So, what we have to do is start raising these issues more and more. This is an election year. So one of the things y'all can do is draw down this sheet that I have on there where it says immediate opportunity to advocate for adult dental services. There's an email address. If each one of you would just send an email in there that says, I am whatever you are, a dentist, a professional, a public health professional. I would support adults getting a dental benefit because that would move the needle. Because that is an opportunity. There's actually a hearing in town here in San Antonio tomorrow to how they can improve Medicaid. So I am never going to be anything less than optimistic that we can get this done as well as every other thing. Yes, the actors we have here are not inclined to really want to do what we want them to do. They're philosophically in the other direction. But, we know we can make fiscal arguments that can appeal. It's not a partisan argument anymore. Maybe one group wants to see the humanitarian side, maybe the other side wants to see the cost containment side. But the fact is, those are both part of the same solution.
Mm-hmm.
Can you repeat the question so I stay on track?
Okay, so my question was really about policies. Some of them are working well, some of them aren't. And Dennis is talking about the need for expansion. And so do you have some reflections and responses there?
One of the first things I did after I finished my GPR, came back to Arizona, I wanted to get involved with the Arizona Dental Association Council on Government Affairs. And I did this because I like lobbying, I like advocacy, and I loved, he has since retired, but I loved our executive director at the time, Mr. Kevin Earle. And as I sat on that council, and I worked with people who had been in the practice for 20, 30 years, very different mindset, different perspectives, different histories, what I realized is that we don't always agree, but I will continue to be a member, I will continue to show up, because if I don't, then I don't get the policies that maybe help the communities that I represent. Not that the people around that table don't care, but they're coming from the people that they represent, just like in Congress and the legislatures. And so we have to, I know we're all too busy and none of us have time, but it really is those simple phone calls. Even if you call up your dental association and speak to them and say, I don't like where things are headed, and I'm a member, so I think I deserve a voice too. 30-second phone calls to your senators and call their local offices, not the offices in DC. Your Congress people, senators, legislators, whoever, call the local city office and leave a message. Sure, a staffer's going to get it, but that your one voice represents something like 10, 20,000 people, depending on the district. I think that's where a lot of it comes from, is just making sure to stay involved. As exhausted as we all are, as frustrated as we all are, if you just shut down or you shut them out, you're going to get nowhere.
Thank you. I think my last question for you today as we close out this session is, if everybody here has heard nothing that you said, but you could just leave them. I hope everybody here has heard everything they said. let me clarify. But if you could just leave people with one takeaway, if you don't listen to anything else except this one thing, what would you leave people with in terms of providing care and advocacy and serving individuals with disabilities? Dennis, I'll start with you.
I'm going to go back to my first statement. You all know how to serve people through dentistry. There are regulations and gaps out there that prevent you from doing that. You could throw up your hands and say, well, I can't do it because there's no Medicaid funding, or, it's just not going to work, and I can't do that. Or what you can do is say, no, I know that's the right thing to do, and I better change that regulation. That's what I'm going to leave you with, and you can do it. And there's some famous quote, and I can't remember who said it, but it's like every positive social change started with a small group of people. Who said that? Who that quote came
Margaret
from?
Mead?
Was it Gandhi?
Margaret
Mead, and it was something along the lines of every positive social change has started with just a small group of people committed to working on that. So there are enough people in this room to do this.
Thank you. Thank you. Scott, what would you leave us with today?
I always tell my students you're going to forget 90% of what we talk about today. Because we're just as adult learners, like you talked about, I'm so glad you all made it to the end of the day listening to us go on for a little bit here. But you will forget 90% of what we talk about. But what's that 10%? Your resources. Know your resources. Don't reinvent the wheel. People have already done this, who've already come out before you, have worked on this. Organizations that are out there, AADMD, American Academy of Developmental Medicine and Dentistry, Special Care Dentistry Association. It's SAID. I forget what their acronym is.
It used to be Southern Association of Institutional
Yeah.
Dentists. Now it's the Special Care Advocates.
In dentistry. Special Care Advocates in Dentistry, SAID, a great resource. They have some great resources. And then, maybe these organizations can connect you with a local person who can be a mentor, either to you or who might know stuff. Maybe you're the policy person, but there's probably someone in your community, and they aren't always loud and proud. Sometimes they're just working in their solo practice, doing their thing, but know your resources, know what's available to you, and if you need help finding what those are, you have us. We can help you.
Thank you so much for joining us today, Dennis Borel and Scott Howell.
Thank you.
Please greet them with a round of applause for their time. And so this will conclude the panel discussion.